those who may be new to the Alliance, we are a nonpartisan, nonprofit organization that for over 30 years has been dedicated to helping policymakers and the public better understand health policy, the roots of the nation's healthcare challenges, and the trade-offs posed by various proposals for change. We're delighted to welcome you to today's webinar, Medicare Advantage Past, Present, and Future. This webinar is part of the Alliance's educational programming for congressional staff and the broader health policy community. Our programming begins with what we call our Listen First approach. We use insights gathered through in-depth interviews and facilitated workshops with health policy experts to shape and inform our work. At a workshop earlier this year, we asked experts, what would an ideal congressional curriculum on health insurance policy look like? To no surprise to all of you, experts highlighted Medicare Advantage as a key component of the healthcare insurance landscape, emphasizing the importance of understanding its history, from the challenges it was designed to address at its inception, to the historic healthcare policies that have shaped both MA and the broader Medicare program over time, and also to the role of Congress in the program's evolution and understanding for where it is headed. So you'll soon be able to read more about the rich discussions and key outcomes from these workshops in our forthcoming Signature Seminars report. Stay tuned for its release. It's coming up in just a few weeks here. But today we're fortunate to be joined by a distinguished group of leading experts who bring deep understanding and insight into how Medicare Advantage has developed and where it may be headed. Today's webinar will explore Medicare Advantage, how it's developed from its early roots, its role for more than 34 million beneficiaries today, and key questions and considerations for its future. We're excited to showcase a range of stakeholder perspectives on Medicare Advantage as part of this event, and hope this discussion will help you all in your work to advance solutions for improving our healthcare system. But before we get started, I want to take a moment to thank our generous sponsors. Blue Cross Blue Shield Association. The Alliance is so grateful for their support in making this conversation possible today. We're here to support all of you and your learning throughout today's session. We know this group will have insightful questions for our panelists, and we'll leave time for Q&A at the end. If we can go to the next slide, but you don't have to wait. Feel free to submit your questions at any point during the presentations via the Zoom chat. If we don't get to your question, please don't hesitate to reach out to us at events@allhealthpolicy.org, and we will do our best to connect to you to additional information. And with that, I am so incredibly pleased to introduce our esteemed moderator today for today's discussion, Carrie Graham. Dr. Carrie Graham is a research professor and the director of the Medicare Policy Initiative at Georgetown Center on Health Insurance Reform, where she oversees a portfolio of policy analysis, research, and technical assistance for policymakers on Medicare Advantage and Original Medicare. Previously, she was the director of Aging and Disability Policy at the Center for Healthcare Strategies. She also holds an adjunct professor appointment at the University of California, San Francisco Institute for Health and Aging. Dr. Graham has been working in the field of aging research, health policy, and evaluation research for over 25 years, including evaluating California's dual financial alignment initiative and other efforts to expand managed care delivery systems for older adults and people with disabilities. From 2018 to 2019, she worked as a Health and Aging Policy Fellow in the U.S. House of Representatives Committee on Ways and Means on Medicare Oversight and Legislation for Post-Acute Care, Surprise Billing, and Price Negotiations for Part D prescription drugs. In 2020, she acted as a consultant to California in the development of the state's master plan for aging, and subsequently provided technical assistance for over 20 states developing their own multi-sector plans for aging. Dr. Graham holds a doctorate in medical sociology from UCSF and a master's degree in gerontological studies from the Scripps Gerontology Center at Miami University. She obtained her bachelor's degree from University of California, San Diego in sociology and African studies. You can read about Carrie in the bios of our other panelists on the Alliance website or on the resources tab on your Zoom bar. And with that, I'll turn it over to Carrie to begin today's discussion. Thank you, Carrie, or Dr. Graham.
You can call me Carrie. Thank you, Sydney. That was a very nice and thorough introduction. And today I'm introducing our panelists. So I'm wondering if do we have the presentation going? Um, All right, so we are thrilled to introduce our esteemed panelists today. The first is John Bloom, who many of you know. He is currently the co-founder and co-managing partner of Health Transformation Strategies. He's also a non-resident senior scholar at the USC Schaefer Institute. And more recently, John served as the principal deputy administrator and chief operating officer for the Centers for Medicare and Medicaid Services. In this dual role, John led CMS's program policy planning and implementation, and also day-to-day operations for the entire agency. He's served as CMS's deputy administrator and director of the Center of Medicare during the Obama administration, leading the agency's Medicare payment and delivery reform strategies and the overall management of the Medicare program. So today, he's going to be sharing with us the historical context and evolution of the MA program over time. Next, I'm really happy to introduce Shawn Bishop. Many of you know her as the former Chief Health Advisor for the U.S. Senate Finance Committee, where she worked running strategic counsel to Chairman Ron Wyden and Max Baucus. In her role there, she led development of major provisions of the Affordable Care Act, as well as legislation on Medicare prescription drug policy, including the Senate Finance Committee passage of the Prescription Drug Pricing Reduction Act of 2019 and enactment of the provision, including the Inflation Reduction Act of 2022. In her current role as senior advisor at Aiken, she empowers clients to anticipate trends, navigate regulatory risks and opportunities, and drive sustainable policy outcomes that align with their business and organizational strategies. She will be talking today about Congress's jurisdiction and why Medicare Advantage matters. And then finally, we have Brian Miller. Brian is a non-resident fellow at the American Enterprise Institute, where he focuses on Medicare payment policy, FDA regulatory policy, and healthcare competition policy. Also veterans health and public health policy. He's currently a practicing hospitalist at Johns Hopkins and assistant professor of medicine and business at Johns Hopkins University. He's a member of CMS Evidence Development and Coverage Advisory Committee and a consultant and expert witness on health insurance for the Bureau of Consumer Protection at the Federal Trade Commission. And today, he will be talking sort of about policies and their impact on beneficiaries and some trade-offs of different policies. All right. I can't see the slide presentation, but if you guys could just, can you guys see the slide presentation? Oh, okay. Anyway, I'm Carrie Graham. I'm really happy to be moderating today. I am part of this new Medicare policy initiative that is this new Medicare policy initiative, here it is, that is fairly new at Georgetown University School of Public, McCourt School of Public Policy. And what we do is we're nonpartisan and we take an honest look at Medicare and especially Medicare Advantage. We do research translation, policy analysis, technical assistance to Congress and the administration, and lots of expert convenings. So that is what we do. And I'm going to also just do a shameless plug today for if this webinar interests you, you're interested in Medicare Advantage policy, next week on Monday, we will be having a in-person with also a virtual option on doing a briefing on Medicare Advantage policies where we have a great panel that's going to be going over lots of different legislation right now to reform Medicare Advantage. Some of the issues we'll talk about today, we'll be kind of doing a deep dive into legislation there. So that is my shameless plug. We'd love to see you either in person or virtually on Monday. Next slide. So I am handing it off to John Bloom now, and take us away, John.
Great. Thanks very much, Carrie. Can you hear me okay? All right. Really want to do kind of several things during these first few minutes, but one to really kind of help give some context to the MA program today, but also talk about its current balances that the program currently serves. The program has many goals that policymakers have set for it. Some of those goals can conflict. We just want to talk about some of the context and talk about some of the reasons why this program continues to evolve and continues to be front and center in the policy context. Go to the first slide. Next slide, please. Brian's going to talk more about the beneficiary perspective. I thought it was just helpful to start here to really kind of give some context to why Medicare beneficiaries choose to leave traditional Medicare, to forego some of the rights they have through traditional Medicare, and join a single private plan to receive their benefits. I think one of the contexts for all of us to think about is for those that stay within traditional Medicare, that it could be quite expensive for them. They have to pay the Part B premium. They have to think about getting separate coverage to obtain Part D benefits. And really importantly, the Medicare program, traditional Medicare, doesn't cover certain things. And so when you add up the total premiums, when you add up supplemental coverage, you take into account the fact that the MA plans often provide coverage for non-covered Medicare services like hearing, vision, dental, that you can see from the beneficiary perspective, there is tremendous value to be had, tremendous cost savings to be had by choosing the program. And so we often talk about the cost to the federal government. Does the program save versus cost? I think looking at a kind of beneficiary perspective really gives context, really gives reason for people to think about private plan coverage. The costs are lower, the benefits can be more generous, and that beneficiaries just need to have one insurance card to receive their Part A, Part B benefits, their Part D benefits, their supplemental coverage, and again, often they receive benefits that are not covered by the Medicare program. Go to the next slide, please. I think one of the program's challenges, and I think one of the sort of kind of context for the past history of the program, but also the current state of the program, is that policymakers have really stated different policy goals for the program to serve. And I think one of those policy goals is to provide benefits that are not covered by the Medicare program, like hearing, vision, dental. Policymakers want competition in the program. They want beneficiaries to have several choices for how they receive their benefits. They want plans to innovate. They want plans to offer delivery models that are more attuned to what beneficiaries may need. They want competition. They want plans to compete. They want that competition to be in all parts of the country, even those parts of the country that don't have a lot of density where you can really see managed care working well. They want to see more care coordination. They want beneficiaries to really have their care coordinated by a single entity for all their benefits. They want quality of care to increase. But I think many policymakers also want the program to save money relative to the costs for the traditional Medicare program. And I think one of the challenges that policymakers have, whether it's CMS, whether it's a Congress, is there are many stated goals for the program, yet those goals conflict. Do you want the plans to cover more benefits, or do you want to save money? Do you want plans to enter all parts of the country? So Medicare beneficiaries have the same access to the same benefits that are offered by the plans. These goals conflict, and I think one of the challenges that Congress has, one of the challenges that CMS has, one of the challenges that all the entire policy process has is that we have to decide how to balance these tensions, balance these goals that again, they often conflict. let's go to the next slide, please. And so during my time working within the space, there have been three major legislative efforts that Congress has passed that really shaped this program. And each of these three laws have taken different takes for how we balance these competing tensions. Going back far in time to 1997, Congress passed the Balanced Budget Act that was really charged with trying to reduce costs of the Medicare program. Congress capped the payments that CMS would pay plans. They directed CMS to put in place stronger tools to think about risk adjustments. They also encouraged more plans to come into rural areas. But one of the things that happened after this law was passed, that plans pulled out of the market, and so we saw fewer beneficiaries in these plans, given the goals of saving money to be the primary purpose of the law. 2003, Congress came back to pass the Part D drug bill that also had many changes to the overall Medicare program. And those policy goals at the time were to really bring back more money to the MA program, to give it more life. And so, following the law, we saw more people go into plans, saw more plans be offered, but we also saw the costs grow quite dramatically. By the time we get to 2010, with the Affordable Care Act, one of the goals of the law was to bring down the payments that the Medicare program paid, but also to really incent more quality improvements through the five-star rating system. So Congress has passed major laws that really shaped this program, but each time has taken different policy goals, chosen to think about the tensions differently over time. And as a result, that we've seen periods for growth, periods for less growth, really following the goals that Congress set at the time. Go to the next slide. But I think some of the questions for us to think about going forward are somewhat different than I think we've thought about in the past. I think the fundamental question to me is, how do we think about traditional Medicare with its cost benefits being so dramatically different from the MA program? And that's a value choice. And the current choice that we're making collectively is that the MA program is far more affordable to those to beneficiaries. Traditional Medicare offers far less benefits, but that's a policy choice. And I think one of the policy questions for the future is, should that gap continue to exist? And should Congress begin to think about adding benefits to traditional Medicare that would bring the two programs, traditional Medicare, the MA program, on a far more equal footing? That's a policy choice. I think the second question for us to think about is, how many choices should beneficiaries have? And whether you talk to beneficiary groups, whether you talk to those that counsel them, whether you talk to healthcare providers, and even when you talk to health plan executives, they would say there is far more choices than any one beneficiary can handle making year over year. And so I think another policy choice for us to think about going forward is, how many choices, how challenging should it be for beneficiaries to make annual choices for how to receive their benefits? A key question that I know Sean will talk about is, how much cost management tools do we want to permit the MA plans to have? And one of the ways that plans can offer more benefits, plans can lower costs, is by having more traditional managed care tools being employed. Question I think that many healthcare providers are now bringing to the Congress is, how should plans use these tools, and what's the right balance between full open access to benefits versus a much more tightly managed experience going forward? The program today, going back to 1997, can even before 1997, is pegged to to the traditional Medicare program. The payment levels, risk adjustment, how we think about quality metrics really go back to that comparison to traditional Medicare. And now that the MA program exceeds more than half of total beneficiaries, one policy question for us to answer is, should the payment systems, the risk adjustment models be really pegged to traditional Medicare? It doesn't really have the same comparison point given the difference in the population, given the difference in benefits for setting these policies. I think the last question, I think to me is the most important one. And while we can look at the two sides of the program, we can look at traditional Medicare, we can look at the MA program, and we can see there's differences in benefits. We can see there's differences in the demographic profiles that choose one program over the other. Beneficiaries who are lower income are far more likely to go into the MA program. But the one question I don't think that we can answer well is, are quality outcomes better for one side of the program versus the other? When you look at the evidence, that you can see differences in payments, you can see that the federal government pays more to the MA plans for the same beneficiary than traditional Medicare. There is debate whether the size of that difference. I think the question we're really trying to grapple with is which program provides better outcomes, better value. I think that we can all agree that far more work needs to be done to really be able to answer that question well of, are beneficiaries better off being in traditional Medicare than being in a private managed care plan? And with that, we'll let Sean and Brian answer those questions because they are far smarter than I. But thanks for the opportunity.
Thanks, John. And I'm not taking the bait on being far smarter because we know that there's a lot of smart going around in this webinar. And so thank you for this webinar, Alliance, and I'm very pleased to be here. And I would love to talk about Medicare Advantage. John Blum and I both started or had important parts of our career on the Hill. And speaking to Hill staffers who might be on this webinar, that you gain so much expertise and experience if you focus on Medicare Advantage. And this program is so large and significant in Medicare today that that experience and expertise will stay with you for a long time. So I'm pleased to present some of the more kind of current issues that Congress tends to think about when it comes to the Medicare Advantage program. Not that different from what John was talking about, but I do want to kind of focus in on what I heard when I was back on the Hill a year ago at the Finance Committee and kind of what the program kind of looks like in its present day. And I'll let John's questions about the future and Brian's presentation about the future take us into that direction. But I'm going to focus mainly on the present. So let's skip to the first slide, which I think is very important. And want to make a plug. This is just a free plug for Kaiser Family Foundation. Has tons of data on Medicare Advantage. I use their resource a lot. There's also public data on Medicare Advantage, and this is all this is from the Kaiser Family Foundation. So basically, I wanted to show this slide because, as was mentioned by John, 54% of and Carrie, 54% of Medicare beneficiaries enroll in MA today. That's over half of the program, and that's almost 30 million individuals. And that share of enrollment, share of total beneficiaries enrolled in Medicare Advantage, 54%, has really grown over time and changed over time. So in 2007, when I was on the Hill and I was working for the Finance Committee for Senator Baucus, and John had preceded me before that, enrollment in Medicare Advantage was 1 in 5, 19%. But it has almost tripled as a share of the program today. And that's just, what does that mean? It means that obviously more beneficiaries are attracted to the program. The program has grown in size, but from a congressional standpoint, it means that members of Congress, when they go home to their district or their state, they're going to hear about Medicare Advantage because half of the program is enrolled and they are going to hear about things they like in Medicare Advantage, but probably things they don't like, because that's sort of, the way democracy works. We want to hear about what things are working, but we're often hearing, members of Congress are often hearing about things that individuals want changed. So now that there's 54% on average, right, across the nation enrolled in Medicare Advantage, all members of Congress, practically all members of Congress, are going to hear about this from the constituents. And they're going to hear about certain kinds of things. I want to walk you through that. But as we move off of this slide, I do want to just say one thing. There is one state that has no Medicare Advantage enrollment, no Medicare Advantage plans are offered there, and that's Alaska. And that's been sort of the case for a while, and that's because it takes really networks of physicians that are willing to participate in an insurance product in order to provide a plan offering. And that just is not really feasible in Alaska, just kind of given its frontier, its geographic structure. But all the other states have Medicare Advantage plans, and except for that one state. Okay, next slide, please. All right, still Medicare Advantage present. Just a little bit of a snapshot that I just took from Kaiser Family Foundation again. No connection to them to me, but they're just a great source of information. Just a really quick snapshot of what they are saying about Medicare Advantage today, and then I have some more detail to add. Okay, so 54% of beneficiaries are enrolled in the program. 1 in 5 of beneficiaries in MA are in a special needs plan. And that's really continuing a very healthy growth trend. So half of the enrollment in Medicare Advantage, okay, of the new enrollment in Medicare Advantage in 2024 to 2025 was in a SNP plan. And that's very material. I want to talk about what that might mean and what that might mean for some of the kind of emerging trends that we're seeing for 2026. But Medicare Advantage enrollment, right, is very highly concentrated. Enrollment is highly concentrated. So individuals who are in Medicare Advantage are largely choosing sort of national plans, and that's Humana and United. And so those two plans of themselves with all of the, and I'm calling them plans, but they're really, let's call them insurers or Medicare or managed care organizations. Okay, those organizations are enrolling half of all individuals who are in Medicare Advantage. So you have a highly concentrated amount of enrollment, but that sort of belies, that sort of concentration belies the plethora of plans that are offered in this program and the number of organizations that participate, right? So as John was saying, there's just a ton of choice in the program, and that's been a goal of Congress's for a long time. So how much choice is there? Well, right now in this year, and a beneficiary, an average, has a choice of 34 plans, and a plan is just a benefit package. Okay, so 34, you can choose from 34 plans today, but half of the beneficiaries are enrolling in organizations from 2 of those plans. 2 of those, let me say that again. Half of beneficiaries enrolled in Medicare Advantage are enrolling in plans from 2 parent organizations, 2 insurers, Humana and United. So there's lots of benefit packages available, but there's still this concentrated enrollment that we have here. So, but what else do we have? We have 30, 35, 36 plans offered today. In 2026, the number of plans available to beneficiaries offered is going to decline. So instead of growing the number of offerings that beneficiaries have to choose from, the number of plans is going to decline from about 36 or 35 to 34. That's still relatively healthy. But what you're going to have to do is you're going to have to look at each state and sort of even maybe each county, because an average snapshot in Medicare Advantage doesn't always tell the story of what's happening in each state. So there's 34, 35 plans available on average, but some states have much fewer plans available, and that's going to decline even further in 2026. And why is that important? Let me flip to the next slide here, if you don't mind. Yeah, so what does Congress, as a member of Congress, what did the chairman of the Finance Committee, what did other members of the Senate Finance Committee really care about when it came to Medicare Advantage? What did they hear about? They heard about enrollment growth, right? They know that a lot of folks in their district or in their state are enrolled in Medicare Advantage, but they're really concerned about stability. So when plans are in the program, that's good. We'll talk about, how they operate in the program. But when plans start exiting markets in mass, okay, let's just say, if plans were to start exiting, that creates an unstable environment for the program. And why does that create instability? Because that means if a plan exits a market, that beneficiary has to choose a new plan. They do not have access to the insurance coverage through Medicare Advantage that they had before. They must choose a new plan or return to fee-for-service. So it creates that sort of disruption, if you will, in health insurance coverage. And so do beneficiaries want to shop for their health insurance coverage every year? Maybe they should, because the plans change every year, but they typically don't. So when a plan exits a market, it creates a choice, forces a choice, a choice moment, right, for the beneficiary and their family. And that's not always comfortable for Medicare beneficiaries. So stability in the program is something that Congress cares a lot about. Now, where have we been? That's the prior slide that I showed, this incredible growth in the share of beneficiaries in Medicare enrolling in Medicare Advantage. It has been a growth environment since about 2010, okay? Very big growth. And where are we right now? Well, some plans are exiting the market in 2026, and we could talk a little bit about that. So, and is that a problem? Still, they'll have tons of choice. Beneficiaries will have 34 plans to select, but some plans, some organizations, some insurers are exiting markets completely. And that's going to create some disruption in certain areas of the country. But me, Sean Bishop, I'm speaking for myself here, I'm not incredibly worried about going from 36 plans offerings to 34. I don't think we're at an inflection point necessarily yet in the program, but members will be hearing about plan exits because their constituents may not have as good of a plan offering in 2026 as they had in 2025, or some of their extra benefits might be changing or being reduced, and that might make them sort of unhappy, and they're going to want to ask their member of Congress or their senator, why is that happening? Okay, and we can talk a little bit more about that. But anyway, growth and stability, huge issue for Congress. But other issues have really been cropping up lately, right? Not just choice of plans, but issues have been cropping up lately for Congress, and that has to do with the way the plans are actually operating in the market. And what I mean is not like back room necessarily operating and where their headquarters are. I'm talking about the kind of operation that touches beneficiaries directly. Those kinds of issues, operating issues that touch beneficiaries directly, come onto the radar screen of members of Congress when something goes awry. Okay, so that's been happening in the last, I want to say 5 years or more. And the areas that where plan operations have been somewhat problematic, or we've seen issues arise, okay, have been in the marketing tactics and the marketing organizations that Medicare Advantage plans work with and their tactics, provider directories, the accuracy of those directories. Okay, so how do you know if your doctor's in your network before you even enroll? Prior authorization, as John mentioned, which is what the plan, how, the kind of the hoops you have to jump through before the plan will authorize a procedure, and then the provider networks themselves. And particularly what was arising when I was on the Hill last 5 years was around behavioral health care providers. Okay, and was there an adequate representation, an accurate representation, and adequate of providers in the plan? Now, I will just say just very briefly, and I want to kind of flow through these other points on my slide quickly to give time for the other panelists. But on marketing, Congress passed a very important law in addition to the laws that John mentioned in 2008 that really sort of I want to say reined in. I don't like to use that word too heavily because I mean this was a very light reining in. Reined in what the plans could do with respect to marketing. And here's one of the things that was taken off the table. You couldn't knock on a beneficiary's door as a marketer for a Medicare Advantage plan without having an appointment, because that was actually legal. Plans could send marketing and enrollment cadres of folks out to beneficiaries' homes, knock on the door, and enroll them right there. Well, that was starting to be problematic because beneficiaries were confused by why was somebody at my door. Sometimes the marketers were representing themselves as they looked like clinical people. It was a little bit of a misleading environment. So Congress decided to say you cannot cold call beneficiaries at their house. As a matter of fact, even the phone was problematic at the time because you could just call beneficiaries unannounced and then enroll them. By the time they hung up the phone, they were in a Medicare Advantage plan, and maybe they didn't quite understand what was going on. No cold calling. You have to have a beneficiary seek out enrollment in a Medicare Advantage plan with a broker or through a website in order to get a response from a plan. So that was sort of reined in. But what's happened lately? What's happened more lately is that plans are utilizing third-party marketing organizations that are helping them market their offerings, right, to in certain geographies. But those third-party marketing organizations or the plans themselves, those might be utilizing tactics that are still misleading. They may not be knocking on folks' door, but are they representing sort of the benefit package accurately? That's something that Medicare CMS always has to look at, because enrolling in a plan is a year-long proposition, and beneficiaries need to know what they're getting into. So marketing is a very important part of how the plans operate. And as I mentioned, directories, prior auths, networks. The other important aspect that Congress hears a lot about and cares a lot about are supplemental benefits. And as John mentioned, and Brian will go into, and supplemental benefits are the benefits that plans can offer above fee-for-service. Okay, and Congress passed another important law in 2018 that allows Medicare Advantage plans to offer not just healthcare benefits, and I'll talk about that just for a second, but non-healthcare benefits that are health related, like transportation, right? These are considered non-medical transportation or food benefits. So plans had more capabilities to offer the kinds of benefits that are considered more supportive of healthcare. And so since then, we've seen this rise in special needs plans, because special needs plans really know how to use those kinds of supplemental benefits. But that sort of issue of what kind of benefits do plans offer, and can they offer supplemental benefits that are non-medical, that was a really big issue for Congress. But what's happening right now? Well, what's happening right now is that plans are taking up these supplemental benefits, but they don't have enough. We, policymakers, the public at large, don't know what plans are offering, because that data is not required to be transparent. And that, I think, is a shortcoming of the way the program is structured right now. We should know a lot more about the kind of supplemental benefits that plans are offering today systematically. And Congress should be able to weigh in on that if they think it's working well, but we don't even have the data. That needs to be fixed. The other thing that Congress cares a lot about is zero premium plans. John pointed out that Medicare Advantage can offer Part B, Part D, and supplemental benefits at zero cost to the beneficiary. That's humongous when it comes to out-of-pocket spending. So zero premium plans are not everywhere in the country, but they are a unique feature of Medicare Advantage. And will the program be able to sustain zero premium plans, or is that even a good idea? So that's something that Congress kind of thinks about and will grapple with at some point. Quickly, the other issues that are on Congress's mind, or have been over the last few years, is this consolidation that I mentioned among the enrollment consolidation in a small number of plans. And then another thing that Congress is looking at, really from this is an issue that's been brought to their attention by certain analysts, and that is that plans are vertically integrated now. They own hospitals, they own provider physician networks, some of them own pharmacies. And so that kind of vertical integration, so we have like horizontal concentration of enrollment, but vertical integration within a Medicare Advantage plan maybe could have some unintended consequences that some members of Congress are concerned about when it comes to fairness in terms of pricing, things like that. That's a bigger topic, but that kind of vertical integration is potentially a concern in Medicare Advantage. And the last thing I will say is this: Medicare Advantage is an important program. Obviously, it's an offering. Over half of the Medicare population enrolls in it. And the cost of this program over 10 years is north of $8 trillion. That's with a T. Okay, so this program has a lot of government and taxpayer funding affiliated with it. And what does that mean for Congress? Well, it means anytime you tinker around with it, and I mean tinker, And we're probably going to be talking about things in a moment that are bigger than tinkering. When you just tinker with this program, an $8 trillion program over 10 years, it's big money. When you want to add things to it, that costs a lot. When you want to sort of require a little bit more provider directory requirements, it costs a lot because the program is large, and we have to just accept that. It also means that if you want to rein in a little bit of the program here or there, do a nip and tuck on the payment piece, or do a little bit of nip and tuck on coding, that's going to save you a lot of money. It's going to be big dollars, but when you put that over 8 trillion, it's going to be an infinitesimal amount of total spending in the program, because that program is very generously funded right now. And with that, I will turn it over to Brian. Thank you.
Hi, this is fun to be here with such a nerdy crowd, and wanted to also add, it's great that over 250 people are showing up to have a very wonky conversation with us about payment policy. So hopefully we're keeping you on the edge of your seats and we're not inducing sleep, because payment stuff can be super technocratic. Couple quick things. One, I previously served 2 terms on the Medicare Evidence Development and Coverage Advisory Committee. I'm no longer on that. I am currently on MedPAC, and noting that my views are my own and not necessarily those of other MedPAC commissioners or MedPAC writ large. And I also serve as a trustee for the North Carolina State Health Plan, which covers 750,000 employees, dependents, and retirees, and it has a group MA plan and also a Medigap plan. Anyway, so wanted to spend a couple minutes talking about beneficiary trade-offs. So when you retire and you've had commercial insurance or you've had ACA insurance, whatever it is that you've had, you need a complete benefits package, right? So you need hospital coverage and skilled nursing facility, or SNF coverage, as we doctors affectionately refer to it as. You also need physician services coverage, right? So that's and physician administered drugs, that's Part B. And then back when Medicare was created in 1965, we didn't even have guidelines for the treatment of hypertension because we had one drug to treat it. Now we have, like 15. And the hypertension guidelines are on their 10th version or something like that. And the first version came out in 1977. So Congress created the Part D program for outpatient prescription drugs, and you need that sort of coverage too, because when you get old, you eventually develop health problems. We're all on a journey to the same place at different speeds. Although some folks might think that, I'm going to a different place, but that's okay. Anyway, traditional Medicare also doesn't have a maximum out-of-pocket limit on A and B. It has cost sharing and a deductible. And so you can buy supplemental coverage. You can buy it as a standardized Medigap plan. That's one option. You can also get it in MA. So what does this mean? So the choice fundamentally Congress has made is they said, you can buy the best of insurance design from 1965 and get an any willing provider network with functionally almost no utilization review. Or alternatively, you can elect to participate in the alternative formulation of Medicare and get Medicare Advantage as a beneficiary. And the plans bid, and fundamentally what they're doing is they're bidding for A plus B benefits, risk adjusted for the population, and they're using a network and some utilization review to reduce the costs. And so if you look at the bids for MA plans, they're around the order, and they vary a bit from year to year. On average, say 82, 86% of fee-for-service costs. And then through rebates and star quality bonus, the plans get additional funds that they deliver as extra benefits to the beneficiary. And I know a lot of folks hear about vision, dental, hearing, and all kinds of other supplemental benefits, but the 2 benefits that matter most to the beneficiary are Medigap coverage and Part D coverage. So if you're in traditional Medicare, you're paying your Part B, Part A has no premium. Part B has a premium of $185 a month, income adjusted. You buy a Medigap plan. The average for that is $217 a month. And then you spend about $42 a month to get a Part D for drugs plan. Or alternatively, most markets have MAPD plans and most of them have a zero premium plan. So you're paying just your Part B premium and you get Medigap and you get Part D in exchange for accepting a network. Could be a PPO or preferred provider network or a HMO, health maintenance network, which is much more narrow. And then you get some utilization review. What do you give up? You're giving up the any willing provider network of fee-for-service Medicare and accepting utilization review. And the question is why is this changing? So there are a couple of reasons. One is beneficiaries are way more used to commercial insurance now by the time they reach retirement. So when you reach 65 and retire now, many of them have experienced with what we might call managed care light or a PPO network or a more assertive or even aggressive managed care formulation in an HMO network. The other thing is cost. So as you can see for the beneficiary, this is pretty appealing. So what does this mean? What this means is if you are poor and retired, you're dual eligible on Medicare and Medicaid. If you are a working class retiree, you're definitely on MA, and you're probably more likely on an HMO than a PPO plan. If you're a middle class retiree, you're probably on MA, and you're most likely on a PPO plan. If you're an upper middle class retiree, some of them are still on an MA PPO plan. Many are in fee-for-service plus Medigap plus a Part D plan. And then if you're rich and a retiree, you're definitely on a Medigap plan. It's sort of interesting. When you look at these marketplaces, the Medigap market, the Kaiser Family Foundation data, which is, I agree with Sean, a phenomenal source. I read it probably daily at the risk of revealing how nerdy we all are, tells you that the Medigap market, varies between 91 to 94% Caucasian, and it's often an upper middle class marketplace. When you look at who's in MA, it's the minorities, the working poor, and the middle class retirees, and then group MA plans also have millions of union and public sectors, such as local, state, and municipal government retirees, because it's an affordable way for those organizations to offer retiree health benefits. From a competition perspective, as you can see, they're very different programs. And I want to spend a moment also talking about sort of provider improvements. So the joke is that I'm both a physician, I'm also a patient. So I've experienced many of these managed care tools from both sides of the table. And I can tell you, prior authorization is not fun. I don't think anyone in the audience is going to be excited for prior authorization, but it exists for a reason. I don't think that prior auth is going to go away, but there are things that we can do to make it better. One is that we do not have an infinite amount of dollars. We have trillions of dollars in the delivery system, and we'll probably have several trillion more with the way that things are going in terms of cost trend and medical trend. But prior authorization can facilitate a clinical conversation about value. But to do that, you actually have to put it at the point of service. So when the clinician, the patient are in the exam room, the electronic health record, and the plan needs to work with the EHR manufacturers to do this, to tell you if prior authorization is required or not. You need to know what your drug formulary tiering is. Ideally, you need that real-time benefits information pushed not into a separate calculator, but that cost needs to be available in the electronic health record so that you can make those trade-off decisions. Now, some health systems and plans are already getting to this place, but I think that's the exception rather than the norm. The other thing is, for prior authorization, electronic health record manufacturers and plans also need to automate data submission. I remember I had a prior authorization as a patient, and there was a fax machine. And I remember just being utterly aghast that in 2025, we are using fax machines. Yet online, we can trade stocks on our phones, send email, book a flight to France. Like there are all kinds of things you can do on your phone. So we need to make one-click submission of data for the patient and for the clinician. And then plans need to use AI and automation to approve and accelerate access to therapy and continue to use humans to review for any denials. There's also been a lot of concern about diagnosis coding difference across fee-for-service and MA. There's definitely some undercoding in fee-for-service and coding intensity in Medicare Advantage. A couple of reasons why. One is some coding is fraudulent, right? Some coding is also abusive, but you could have an argument and hire an expert and a lawyer to debate whether that's correct or not. And then some coding intensity is clinically appropriate because in MA you have an incentive for coding intensity and fee-for-service you don't. And so from a clinical perspective, you want beneficiaries coded completely and accurately. And you want the clinician at the point of care overseeing that. But what you don't want is the current system where clinicians are forced to do administrative tasks like coding. A lot of diagnosis coding can and should be automated at the point of care with clinician oversight. We also need better financial and physical evaluation of the Medicare program writ large, which is both MA and fee-for-service. Next slide, please. So we need to do 3 critical comparisons to compare MA versus fee-for-service. One is we need to look at program entry. So around 2.8 million people enter the Medicare program every year. And we need to compare the choices and the populations that beneficiaries make at enrollment. We also need to look at the population of beneficiaries who stick with fee-for-service or MA, which is something on the order of 96 or 97% of beneficiaries every year. Then we also need to look at the folks who switch from one plan to another, which is around 2 to 3% per year, and then compare that to the folks who did not switch. So what does this mean? So analysts, MedPAC, and other organizations have looked at a one-way switching population, but we really need to look at both directions of switching, compare beneficiaries who stick with either program, which is 95% of the population, and also look at the millions of people who enroll in the program every year and have a 3-stage comparison by population. The other thing that we need to do to have a complete evaluation of fee-for-service and MA is to look at the program from three sort of lenses, in addition to the 3 populations. One is to compare per benefit component spending for society, Part A, Part B, Medigap, and Part D, in which case many of us would probably suspect that MA at that point is delivering better value. You then also need to look at total holistic health benefits package spending, which is A plus B plus D plus Medigap. Again, you could debate, but there's probably, because there are managed care tools, Medicare Advantage is going to be cheaper. But then we also need to look at statutory program spending, which is comparing A plus B fee-for-service spending versus MA program spending. In that situation, Medicare Advantage is probably several percentage points more expensive. And so this will give us a better evaluation about the populations and the distribution of disease and expenditures across program when we look at the programs, when we look at 3 population comparisons and 3 benefits structure comparisons. For future directions, I'll be brief because I know we want to have some time for questions. One, I already mentioned we need a better evaluation framework. We also need to recognize that Medicare is a population of populations, right? So Congress did this with the special needs plans, which I believe were reauthorized 6 or 7 times before it was made into a permanent program. But creating space for the duals, those who live in long-term care or the institutionalized population, chronic disease families, the more elderly we become and the more diseases we develop with time, the more customization and personalization of care and some degree customization of benefits that we need. Beneficiaries have agency and make choices over the age of 65 that other non-elderly Americans make, such as purchasing over 500,000 homes a year, boats, cars, and other forms of insurance. But they do need better filters, such as improving the plan finder and having better provider directories, which also gets to CMS needing to be a stronger regulator, right? So that mission of contracting for a fee-for-service plan and setting prices is in conflict with pragmatic and assertive regulation of the MA program. And then on top of that, I know a lot of folks have talked about improving fee-for-service benefits. I would say that we also need to improve fee-for-service operations, right? And allow and empower MACs, or the Medicare administrative contractors, to take actions to fight fraud, waste, and abuse, and reduce Part B premiums, or even pay certain providers that we don't have great access to in the Medicare Fee-for-Service program, such as psychiatry, more. And I look forward to everyone's questions and admire everyone for sticking us through this entire hour of quite possibly the nerdiest conversation in Washington.
All right, Brian, speak for yourself on nerdiness. I spend a lot of times trying to tell my teenagers how interesting Medicare is. They don't believe me. We wanted to start with some questions today. Thank you all for your wonderful presentations. And I do think we have a little bit of time. We have some great questions coming in. I wanted to start with you, Sean. One of the major things that's attractive about MA plans are these supplemental benefits. We got dental, vision, and hearing, but then we have these special supplemental benefits that are non-medical benefits.
Yep.
And you mentioned the transparency issue and how we really don't know who uses those, how much they cost. And the special supplemental benefits are supposed to impact health-related social needs, but we can't look at that right now. I know there's new reporting coming in, but right now we can only say what percentage of plans offer certain kinds of benefits. And this has implications for evaluation, and it also has implications for beneficiaries being able to choose a plan. So can you just tell us a little bit about the kind of transparency you would like to see in supplemental benefits to really be able to say, are these really addressing health-related social needs?
Yeah, no, it's just a great question. I'll be brief because I know you have a lot of great questions here. Just quickly on supplemental benefits, just first of all, just to level set quickly, supplemental benefits is a broad category. And as you mentioned, they can be medical and then they can be non-medical.
Mm-hmm.
We have insight through encounter data, that's the word for claims data in Medicare Advantage, on the medical benefits. We understand a bit about that. That data is still being improved upon because plans are learning and to submit that data accurately, but we do have some insight there. And then it's the non-medical benefits for plans. We know what they're offering, but we don't know how it's being utilized. And a lot of those added benefits are being administered by third parties. So, there's a lot of distance there. And so if Congress is funding these supplemental benefits by allowing plans to utilize their rebate dollars, why wouldn't we want to know who's using what? That's one thing. Congress should know it. Congress needs to know how this program is operating. It's just the way that it is because nobody else is in charge, you know what I mean, of this program like Congress is. Congress sets the law that determines what these plans can do. So it's incumbent upon Congress to have its traditional oversight in order to understand how the program's working. But I think for researchers, I think it's important to know, like, well, which of these extra benefits really work? like you could do a great analysis over time. So I feel like there's more value we could get out of that transparency through learning and kind of learning what works. So I'll leave it there.
Yeah. I'm going to turn back to you, John. So looking back, what would you say are the most common misconceptions about how MA has been designed, or the intent that policymakers and stakeholders should keep in mind when discussing future reforms?
I think Brian kind of said it well, and I think there is, perception that beneficiaries that choose the MA program, they do it through kind of full choice. They do it through, kind of full agency. I think the fact of the matter is that lots of beneficiaries don't necessarily have the choice not to be in the MA program. Certain dually eligible beneficiaries, when their state coordinates Medicaid benefits with an MA plan, in order to get access to the full Medicaid benefit, they would have to go into the MA plan. For those that want to continue retiree coverage, they often have to go into the MA plan that's contracted with the retiree benefit plan in order to get the full benefit to their Medicare benefits. I think there are beneficiaries that go through the annual choice process and make a decision whether they go through traditional Medicare or to an MA plan, and they choose the MA plan that's best suited to their needs. I think there's a growing share of those covered by the Medicare program that don't necessarily have full agency. And I think we have to recognize that in our policy. And we also have to recognize that through how we regulate the plans that, for some, don't necessarily have the full choice. And I think that's why we have more kind of scrutiny to the choice process today that we've had in the past, given how many people don't necessarily have, kind of full choice not to be in the program.
Yeah, one point on that, I think, which is really important about what John said, is that fee-for-service Medicare is super expensive. And the reason it's expensive is it remains the only payer market with any willing provider network and almost no utilization reviews. So when you look at the ACA market, when you look at the employer-sponsored insurance market, when you look at TRICARE, when you look at the VA, when you look at Medicaid MCOs, almost all of those have a network. The VA has arguably the strictest network, followed by TRICARE, or maybe Medicaid MCOs, but almost all of them have a network, and they definitely have assertive or moderate utilization review. Fee-for-service Medicare doesn't have those. So I think what we're actually seeing, it's not just the loss of financial agency, it's that the 1965 insurance model is just too expensive when you have lots of drugs and technology, and you have a life expectancy where people can live for 20 or 30 years in the public benefits program.
Can I just add real quick onto that, and just to kind of give the congressional perspective? When you're talking about health insurance, where the perspective from members who I interacted with, just last year, these were largely on the Democrat side, they see a lot of money going into Medicare Advantage. And that's because healthcare is expensive for individuals who are elderly. They utilize more healthcare. Okay, that's a need. A lot of it's need. When that happens, and then you have strict prior authorization or limits, not just on the provider directory, but on the service that you are eligible for, members get very nervous. Okay, because they're not sure how those restrictions are being applied. Is it the physician that's applying it? What we're talking about is an outside organization, a plan, or even one of their third parties that are putting a restriction on what the doctor is prescribing. We have to be very careful about that, not because I don't think that every decision that a physician makes is accurate. Okay, sure, we could have some, there's a role for looking at the appropriateness of this, but that is very hard to do. And members get nervous when they are hearing from beneficiaries that are not getting access to post-acute care or home health, or some of the things that are very that members think that plans should be providing access to. So we have a tension here between being prudent about allowing physicians to prescribe, and then members understanding how these rules are being applied. And that's where Congress can and needs to step in, because I'm concerned that the agency, Medicare, on its own, with the current authority, does not have a ton of authority to really regulate. I think that's why we saw an industry agreement with this Trump administration on prior auth. It's going to be hard, to really rein this in unless Congress might need to step in and sort of direct here. And I'm going to leave it at that. But this is a very important issue.
Yeah, no, I agree. And I think that there are a lot of things that can be done and should be done with prior authorization. A lot of it, I think, as a physician, I think the reason a lot of people are angry is because of the process, right? So that process
Takes a long
is
time. Takes too long.
antiquated. Well,
Sure.
it's an antiquated process that works like the filing cabinet that's, off screen here in my home office, right? It's paper, it's slow, it's not instantaneous or near instantaneous for even approval to access therapy. And so I think that's primarily an operational issue. I do think CMS has plenty of authority to address it. And I think one of the tensions with MA is that, do we want Congress spending time setting population health goals, addressing interoperability, technological innovation? Or do we want Congress to have a debate about the payment level for 99214 E&M service in fee-for-service Medicare because a physician group has shown up as upset about it? And so those are the two the political economy of MA and fee-for-service is quite different, because in fee-for-service, it drives everyone to go to Congress for their item in service, access to their item in service, coverage for their item in service, and pricing for their item in service, and sort of crowds out important conversations. So I would actually say the fact that we're even having a debate about prior authorization is refreshing, because we're not debating the price for levels or price levels for items and services. So we're actually already making a positive transformation in thinking about how we regulate and oversee a marketplace.
If I could, Carrie, I would love to know John Blum's view on this.
I think a couple thoughts. We can think about prior authorization in kind of several categories. We can think about it as a payer should put in place checks and balances to make sure the healthcare services are appropriate. They're consistent with the contract. That's kind of one level. Another level is to really engage beneficiaries. You want to get them to take part, like in various care management programs. You often need prior authorization to identify the patients that could best benefit from those programs. The third category that I think is probably more common is to restrict care, to really kind of manage the care and make the plan more affordable for the shareholders. And I think that those first two categories, I don't think there's a lot of debate. There is a role for prior authorization to ensure that the service is safe, to ensure that the benefits are consistent with the contract. There's prior authorization that has really positive benefits to engage beneficiaries to certain care management programs. I think we're really debating regarding that third category. What's the right level? What's the right mechanism? And how often should plans use those services? I do think there is consensus to be had. I do think there is very strong public policy purpose to prior authorization. But I think we're debating this third category of what's the right level, what's the right balance, and to Brian's point, kind of how do we take some of the friction out of the system so plans providers don't necessarily kind of have to navigate through processes that can feel quite hard.
I agree wholeheartedly with John, and I would say that there's an important thing for, I think, all of us and those listening to think about when we talk about prior authorization. So prior authorization is a manifestation of utilization review, right? So it could be prior authorization, it could be step therapy, but I think the thing for us also to be cognizant of as we're sitting here, and as a physician, obviously, I'm very happy that we're obsessing about prior authorization, right? Because I would like selfishly, I would like, my clinical life to have less friction from managed care. That aside, the alternatives to prior authorization, when you turn down those dials, one is there's a deterrent effect from prior authorization where, yes, it captures a large number of people who are doing the right thing and it's annoying, which is why we should decrease that friction. But if you turn down too much, then the people who it's supposed to sort of scare out of the behavior go back to that bad behavior, fraud, waste, and abuse. So that's a trade-off. And then the other trade-off is the trade-off of not having prior authorization is to also just, the alternative is not having access to the services. So, and it's not that either one of these is the right answer. It's just sort of a gradation of we have a non-infinite amount of dollars to spend on healthcare. And so on one side, you could have a more dynamic model, which definitely needs more oversight, active oversight of prior authorization and utilization review practices. And at the other end of that spectrum, you have the VA, which I love and adore and trained in medical school and residency. It's a lot of fun, love the vets. But in the vets, there really isn't, in the VA, there's not a lot of utilization review because there are some services which you simply don't have access to, right? Or the access is we have one echocardiography machine, the other hospital has 5, and you just have to wait to get your echocardiogram. Or in the case of Viagra, you only get, 4 tablets a month, right? And that's what the drug formulary says you get. And I know that these examples sound ridiculous, and I'm not saying them to be ridiculous, but there are multiple ends of the spectrum for how you can control and address utilization. Prior authorization is one of the more flexible ones. The alternatives involve taking things off formulary or putting, numerical restrictions or decreasing the number of ways in which we can deliver items and services.
Yeah. Thank you. I think this gets us, prior authorization is one of the most important things about beneficiaries' experiences. And we've seen so much just in the public, in social media and the news about that. But I think it really is a good transition to beneficiaries' experiences. So, Brian, you mentioned switchers, and one of the things we talk about choice in Medicare Advantage, and one choice would be if you're an MA for a while and you maybe get tired of the prior authorization or the limited provider network, you want to switch back to traditional Medicare. That then usually for cost requires a supplement plan, a Medigap plan. So why is that? Why is needing a Medigap plan make it difficult for people to easily choose to go back to traditional Medicare?
So there are 2 answers. One is most states don't have community rating or guaranteed issue. They have individual rating based on your medical experience, which is a state insurance regulation decision, which makes Medigap more expensive when you leave MA in that state and go back. Now, even if we fix that, actually, unfortunately, at the state level, most market research shows that the switching goes from, say, the low 2s to, the mid to high 4s in terms of percentage. So you do offer an escape valve, which, is a reasonable thing for states to consider doing, but Medigap is still fundamentally super expensive because what Medigap does in most of I think it's like 3/4 or 4/5 are enrolled in Plan F and Plan G, right? So Medigaps are offered as an alphabetized standard. And if you look at Plan F and Plan G, Plan F has no cost sharing whatsoever, no copays, no premium, no deductible. And then, Plan G adds a little bit of a deductible back. And that's fundamentally a very expensive insurance product. So there are things, as I said, that we could do to sort of bring down the cost of fee-for-service, right? If you think about it, we could consider Medigap reform, obviously politically unpopular. That'd be a great way for us to all be attacked with pitchforks, but that is an option. Another option is, again, to sort of give the MACs or the Medicare administrative contractors some additional tools, such as reintegrating the fraud, waste, and abuse function into the MACs, and then you let the MACs, say, rebate those dollars to the beneficiary to reduce premiums. And that would be a way that you could make fee-for-service more affordable to the beneficiary and sort of try and preserve that choice without massively expanding the cost of fee-for-service Medicare. Because anytime we play with the fee-for-service Medicare benefits package, I mean, the numbers we get are huge.
Yeah.
And so
So,
affordability is critical.
yeah, being able to afford to switch back if the people really are supposed to have a choice. John, I want to turn to you and just ask you, what are we seeing these days in terms of beneficiaries, how they perceive their experience? What is the data showing in terms of beneficiary experiences with MA?
I think, I think it's hard to sort of have like one broad statement for all beneficiaries, given that the program is so large and everyone has different experiences. I think when I was working with CMS, I would travel across the country. The overwhelming sort of concern that I heard is that it's a kind of very complicated process. And it takes someone to really kind of walk you through the different choices. Many beneficiaries rely on counselors, SHIP counselors who are volunteers, doing phenomenal work throughout the country, but it's hard to get access to that resource. What I heard during my time at CMS is the process is complicated. The time period to make a choice is very constrained. There's fear that you're going to make the wrong choice that then has consequence for the next year, possibly the rest of your life, because it's very hard to go back to traditional Medicare. I think we need to think through like how we design a process that promotes choice, that promotes beneficiaries to consider the best experience for them, but at the same time, take away the fear. And what I saw, what I heard through travel across the country is there's far too much fear that someone's going to make the wrong choice. I think we really have to think hard. Does that mean that we have to constrain choices? Do we have to really think about more resources to provide more beneficiaries to have access to SHIP counselors, for example? So I think that's a fundamental choice and concern that we have to think hard about, is that if we want the program to have competition, and there is tremendous value to competition, but on the other hand, we also have to think about how much competition is right, or to achieve the goals that we want, how much competition can any one person really navigate through, and what are the tools support somebody needs to feel confident with their choices, that they're making the right choice for themselves, for their spouse, and not worry that that's going to have consequence for the rest of their life.
Yeah. Sean, this is kind of an interesting question. It's, we've been hearing about providers and health systems leaving MA, not having MA, certain MA plans be pulling out of the provider networks.
Yep.
And we didn't have a question. It's really kind of a payment question. So why are providers pulling out of MA provider networks while we're hearing about MA plans being overpaid? So can you kind of break that down? If MA plans are overpaid, why are providers pulling out?
That's a really great question. It's a really great observation. And I think we should talk about the overpayments, and maybe the folks on this webinar have already been reading about that. But yes, on the provider side, members of Congress hear a lot about that, because the providers have been, in the last few years, I would say overburdened by processes that are related to payment and prior authorization. I mean, Brian alluded to it, and John, there's friction in the system for the provider. And so they don't feel like it's easy enough for them to give the kind of care that they want to give to their beneficiaries. So hospitals in particular can be really squeezed by having to put in documentation to substantiate certain kinds of admissions. That you have to hire people to do that. That doesn't come out of thin air. So they have to hire people to do that. At the same time, the plans are probably looking to squeeze down provider, payments to providers to below fee-for-service rates. I mean, that's sort of a little bit of a, of a red line there. Can a Medicare Advantage plan, if they're getting paid fee-for-service or some factor of it, can they get the providers to accept lower than fee-for-service? So yeah, there's been some dissatisfaction. One thing I just read this week is that the Mayo Clinic, which is a regional but very prestigious institution in the United States, operates in Florida, Minnesota, and Arizona, is leaving Medicare Advantage completely. So if you want access to certain providers, Mayo Clinic or certain hospitals in certain parts of the country, you will need to go to fee-for-service. And that's sort of a little bit of a long, I would say 3 or 4 years this has been in the works, because there's been so much friction. I'm just going to use the word, we can unpack that. Friction between the plans and providers. We're starting to see providers say, I'm out completely.
Yeah.
Yeah,
So providers can leave anytime.
Yeah.
So couple thoughts on that.
And,
One is,
well, I think John was going to say something, and then we'll move to you, Brian.
Just to add some thought to that, and it used to be the case, 10, 15 years ago at CMS, the hospital CFO would say the MA program provides far better value to them. They get paid better, they get paid faster, they don't have to go through all the fee-for-service kind of hoops. And to Sean's point, that dynamic has really flipped. And I think when you talk to hospital CFOs today, what they say is that the net payment they receive from plans, given the fee schedules they receive, given the prior authorization friction, the cost it takes to kind of get the claim negotiated, that is often the case that traditional Medicare is the better payer. I think we have to think about that shift that's happened over time and what that means for beneficiary networks. And I think if that dynamic now is that providers feel that traditional Medicare is a far better deal for them, I do think that's going to really threaten the strength of provider networks and the overall value proposition for the MA program.
Yeah. So a couple thoughts. One, obviously the prior authorization friction, I think we all agree needs to be addressed. I will say that the actual share of hospitals leaving MA plans is very small in terms of, out of the 6,000 plus hospitals nationwide, we're talking a percentage point or two are leaving an MA plan in an average year at most. So that the absolute number is small. I think the other important thing for us to look at, when large elite quaternary care hospitals leave a Medicare Advantage plan, I think the important question that we should ask any of them is, do all of their departments participate in fee-for-service Medicare and accept new fee-for-service Medicare patients? Because one of the challenges at quaternary care centers for a Medicare beneficiary, whether or not they have fee-for-service or MA, is even if the facility is enrolled in either program, they often aren't taking new patients, or such that the length of time that the Benny has to wait for that subspecialty care is long enough that they functionally don't have access. And so I think that one of the things that reminds us is that having a Benny have choice to a large quaternary care center that offers access is arguably more important than whether they have choice of access to multiple quaternary care centers or a specific quaternary care center. So if I can get an appointment at MD Anderson in 2 weeks, and that's in my fee-for-service network or MA network, that is phenomenal access. If there's another large quaternary care center that is only in one fee-for-service, or it's an MA, right, and fee-for-service, but I can't get an appointment for a couple months, that is fundamentally not access for the beneficiary. So,
John, you had something to say here.
Just real quick, Brian, I'm not trying to, I just want to add two thoughts to this. I think it's a very important point that Brian's making, both of the points, and I also agree with him on, this is a small number, but if I'm speaking to health staffers, and I'm putting my old hat on, I'm looking at trends. I'm always looking to see, is this a canary in the coal mine? I need to know what's coming down the pike. And so nobody's running for the hills or saying that, the sky's falling. But when you start to have the providers, they were complaining when I was on the Hill, now they're leaving. Okay, so how big is this going to be, and can the plans rectify this? And I'm not saying that's everywhere in the country, but we've got to look at this. Congress has to understand what's going on here. It's responsible for this program, so it's more just kind of keeping an eye on it. But I will say this, Brian, and folks here. When I was on the Hill, we had a situation in Oregon where a good, hospital system was leaving Medicare Advantage. And we sat them down, what's going on? They said, here's what's going on. We provide, and we're in the middle of the country, this is not Portland, okay, where we have access, as you're saying, Brian, to other hospital systems. We're it. And these plans are telling us how to provide care to patients with cancer, and they're not correct. They are wrong on the clinical guidelines. And that was a problem. They're like, we're battling them on how to provide the right care to cancer patients. That was enough for them to say, if you want to push us to this point, we will leave your network because you're making us provide not good care. And they battled it out with the plan, and they changed the plan. Its kind of like prior auth guidelines. But that's what it came down to. It's not just friction. It's just like they're going to have us provide bad care, and we're just not going to do it. So it's deeper than that. That's what we heard, and we didn't get involved because these are private agreements. But just knowing that, it made us pause. Like, okay, the plans. Why are the providers leaving? Somebody needs to ask that question. Why is Mayo leaving? I've asked them. It's important to know, because that's how the Congress needs to understand how the rules are being effectuated right now in the program. Anyway, it's something that Congress always needs to pay attention to.
All right. We only have time for one more question, and I want to make it about rural areas because it's been such a hot topic. And there's been so much concern about rural areas, and maybe John, I'll hand it to you. One question is from the audience. It's really difficult to offer an MA plan in very rural areas. Do you see any changes or suggestions for changes in rules in the future to allow more flexibility to offer MA in rural and frontier areas?
Well, I think that two things. Number one is that CMS through time has given more flexibility to the plans to build networks through telemedicine, for example. So you don't necessarily have to have the same concentration for a given provider now that we can see providers throughout the country and don't necessarily have to travel to them. I think that's one step. I think that we can think more creatively over time for how to think about what constitutes a planned provider network to ensure beneficiaries have really good access to care. I think the other question is we have to decide kind of what is the network that a beneficiary is entitled to and join the MA program. And we might want to think about different standards for parts of the country that are urban versus parts of the country that are rural. Today we have kind of one general provider network standard that has some flexibility around telemedicine, but that's pretty much it. So I think that's a policy choice. And I think we can decide that the MA program needs to be consistent for all parts of the country, or that we can decide that due to demographic, to geography, we just can't necessarily have the same degree of provider network, but through technology, through telemedicine, that gives us more flexibility for the future to kind of weigh some of these balances going forward. But I think there are clearly beneficiaries that want access to the benefits, to the cost sharing, and I think Congress is always going to respond to that demand. But then I think we have to think about the second order question of what constitutes provider network, what is reasonable, and can technology help to solve some of these barriers.
All right. Well, thanks everyone. We've hit our time. We're gonna thank you so much. I'm sorry we didn't get to all the questions, and handing it back to Sydney from Alliance.
Thank you all so much, Carrie, John, Sean, and Brian. What a phenomenal panel it was today. So many insights shared. We really appreciate it. And I want to thank all of you who took the time to be here with us today. We hope you found this discussion informative and that you can apply it to your work. And before we go, of course, we want to hear from you. Please take the survey. It'll, inform our work moving forward. We will also be sure to follow up via email and share this link. So if you want to take it then, that is that option there as well. And also, on looking ahead on November 18th, we'll be hosting our Health Policy Forecast Symposium and post-symposium evening reception. This forward-looking event will explore the forces shaping healthcare in the year ahead through panel presentations featuring health policy experts. You'll hear insights into what's ahead for the administration and Congress and what it means for the future of healthcare and Medicare. So please be sure to join that if you can and register. We'll drop the link for that in the chat. And the event will conclude also, again, with an evening reception at Astro Beer Hall. If you've ever been there, food is delicious. I just want to add that. So if that's a draw out for you, please be sure to make it out. And then finally, as a reminder, a recording of this webinar and additional materials will be available on the Alliance's website in the coming days. So this concludes today's webinar, and we look forward to seeing you at future Alliance events. Thank you all so much for joining, and thank you to our expert panelists. Bye, everyone.